Thank you all for coming today. My name is Chae. I'm a PhD candidate in the sociology department at Cornell. Today, I'm going to be sharing what is now my qualifying paper titled Abortion Clinic Access in the Post-Dobbs Era, Measuring the Effect of Abortion Bans on Distance to Clinics. So to start with some background, since 2010, we've seen an overwhelming number of abortion restrictions across the country that make it purposefully difficult and nearly impossible to get an abortion. According to the Guttmacher Institute, from 2013 to 2015, there's been approximately 40 abortion restrictions introduced every year. And some of these examples include targeted restrictions on abortion providers, also known as trap laws, mandatory waiting periods, banning abortion coverage through Affordable Care Act, and many more. But when Roe v. Wade was overturned in 2022, this marked the peak of this hostility towards abortion and reproductive health care. According to the Guttmacher Institute, after just 100 days after the Dobbs decision, 66 abortion clinics were forced to shut down or stop offering abortions altogether. And this context is extremely concerning for very clear reasons. In the United States, abortion rates were reported to be 11.6 per 1,000 US women aged 15 to 44 in 2021, and 95% of these abortions are reported to be conducted in clinic facilities, meaning that only 5% are done in private physicians' offices. But not only do clinic facilities offer abortion, but they also offer holistic sexual health care support like STI treatment, family planning services, gender affirming care, and miscarriage management as well. So clinic facilities, all in all, play a very crucial role in guaranteeing access to reproductive health care in the United States. Following this context, prior studies have examined the additional burdens associated with these restrictive abortion legislations and the increasing costs of out-of-state travels. But an overwhelming number of these studies have focused on states like Texas, Wisconsin, and Indiana, those that have introduced indirect abortion regulations prior to the Dobbs decision. So, for example, evidence from Texas points to an increase of 20 miles from each zip code between April 2013 to July 2014 following the enactment of the trap law, while Wisconsin experienced an average increase of 55 miles across counties following 3 restrictive abortion laws. While more recent work also confirms an increase in travel distance across all states, as well as some scarring effects in other reproductive health services, most of these observations are descriptive and observing limited time periods after the Dobbs decision. So, situating this context in the broader literature, we know that political and economic contexts are important determinants of reproductive health. Political contexts, especially in the forms of laws and policies, have been highlighted as important determinants of health inequalities. So, for example, whether that be state-level immigration policies, vaccine policies, or environmental policies, all of these have direct implications on one's health. Most importantly, these political contexts are also inherently spatial that have implications of diverging health outcomes across space. So Montez's work notes that since the 1980s, state policy contexts have become even more polarized, diverging major health outcomes like life expectancy across different states. And the Dobbs decision creates this new spatial disparity in abortion and reproductive health care as well. And therefore, research can imply that with trends of high state polarization, it also has diverging trajectories in women's reproductive health outcomes, propelling spatial dynamics accumulating on top of pre-existing socioeconomic health disparities. But these political contexts cannot be isolated from other socioeconomic determinants of health either, especially where a major obstacle towards health equity is the affordability of care. In the United States, where health is already stratified by race, economic status, educational attainment, this is no exception for reproductive health. What I want to specifically focus on today is the affordability aspect of care. And this is because although low-income women experience higher rates of unintended pregnancy, the usage of reproductive health services is much lower among these subgroups. And especially when it comes to abortion, one of the most common reasons for delaying care is the travel and procedural costs, which have only increased with restricted access to abortion post-Dobbs. So, bringing all of this literature together, I'm asking two main questions in this paper. So, first, did total abortion bans increase the distance to nearest abortion clinics across all total ban states? And if so, what is the magnitude of this distance change? When a total ban is introduced and procedural abortions become illegal and subject to legal consequences, it's quite obvious that clinics will close down and this increase in distance will happen. But whether how much of this and the magnitude of this question still remains unclear because prior research that measures these causal effects of abortion regulations on clinic accessibility are restricted to a few states and mostly done during pre-Dobbs periods. So this research kind of looks at whether these effects are generalizable across all 12 total ban states, and it tries to answer that question that remains unanswered. Number two, I'm asking, are there disproportionate effects of the total ban among women in poverty? From the literature, we know that there are negative associations between economically disadvantaged neighborhoods and their utilization of reproductive healthcare services. So this gives us a reason to think that women living in poverty may experience larger travel burdens as they live in census tracts or areas and neighborhoods that are further away from abortion clinic access. But this isn't necessarily a given fact. In other words, a contrary hypothesis could also be true. This is because, at least in the United States, 56% of Planned Parenthood facilities, which are crucial sites for abortion care, were located in medically underserved and rural areas purposely to serve this marginalized population. In addition, while poverty is a key aspect to affording reproductive health care, the geographic access is also dependent on one's neighboring state that may provide additional access to clinics out of state as well. So, what the actual dynamic looks like and whether the experiences of travel are disproportionate for economically disadvantaged women is also an empirical question that remains relatively unanswered. So this paper is contributing to the existing literature in also two ways. So first, by measuring the effect of total abortion bans that were enforced through the trigger laws after the Dobbs decision, I'm yielding estimates that are not only limited to all forms of restrictive legislations pre-Dobbs, but I'm also finding a generalizable effect across all 12 total ban states. But also, there's no research so far that shows long-term effects over time, but this data set allows us to look from 2017 to 2025, looking at persistent effects of these total abortion ban laws. Second, this paper is examining how these polarized contexts interact with pre-existing economic inequalities. So in other words, we can examine whether there is an aspect of multidimensionality in an inequality, whether health inequalities are accumulating on top of each other, or are these spatial inequalities equally experienced among different subgroups. So the data I use for this paper mainly is the abortion facility database provided by the UCSF Advancing Youth Standards in Reproductive Health. This abortion facility database is collected through publicly available resources and mystery shopper phone call methods. It's collected every year from June to August with a cross-checking process through the month of September. A strength of this data set is that it's intended to catalog facilities that women seeking abortions can readily identify in the phone book or an internet search. So it really replicates the real life experiences that women have to go through in order to find an abortion facility nearest to them. I'm collecting state-level abortion ban policies from the Center for Reproductive Rights, and I also use the Americans Community Survey 5-year estimates for basic tract-level characteristics such as population under federal poverty thresholds for the poverty weights used in this analysis. And I also have IPUMS and HGIS for Census Bureau tract-level geographic coordinates. Before moving on to the model specifications, I'm going to go through a few definitions of the analysis. So first, when I talk about clinics, these are specifically brick and mortar sites, and I'm excluding telehealth services. This is because telehealth services usually don't have geographic coordinates, but it's mostly because brick and mortar facilities still account for approximately 80% of clinician-provided abortions in the United States, both medication and procedural, even after the Dobbs decision in 2020, as of 2023. Also, this kind of provides a more inclusive definition of access because for patients that are 12 weeks or more pregnant, medication abortion no longer becomes a viable option, making in-clinic procedures their only choice. In addition, studies have shown that Black and low-income individuals are more likely to opt in for procedural abortion rather than medication abortion, which kind of highlights the importance of brick and mortar clinics for marginalized communities that face more systemic barriers. So if we do include telehealth clinics in the analysis, this may overstate access for patients that are at various stages of pregnancy that may not actually be able to receive the care they need, and therefore brick and mortar facilities are the main sites to look at for this study. When I say distance, this is measured by a Euclidean distance, which is basically measuring the straight line distance from a center point of a census tract to the nearest available abortion clinic that's available for them. In the main analysis, I exclude Alaska and Hawaii because of their own unique ways of travel, but even including them in the main analysis does not change the results substantially. And in order to measure the effects of total ban among women in poverty, I use analytic weights in the analysis that are defined by the total number of women in each census tract, ages 15 to 44, living under the federal poverty threshold versus women that are living above the poverty threshold. So the total effect size that I'm yielding here can be interpreted as the average distance that women of this population will have to travel and the difference in the distance that women in poverty have to travel additionally in comparison to those that are above the poverty threshold. And using these poverty weights allow the analyses and the interpretations to be done at the individual level rather than analyzing this at simply the census tract unit. This also gets at a unique unit problem where a lot of these census tracts in the United States that are located in rural areas are just large in size, therefore entail a lot of distance, however, may not have a huge population of women that are in the ages of 15 to 44. So this may actually overstate the poverty disadvantage when we just look at census tract level distances, and therefore using poverty weights kind of gets at this unit problem as well. And the most important definition here is the treatment. So the treatment is defined as states that had a trigger law go into immediate effect with the Dobbs decision without any injunctions. So what's unique about the Dobbs decision was even before Roe v. Wade was overturned, 15 states in total already had a preemptive law in place, which is known as the trigger law. And this trigger law is basically an on and off switch that allows states to immediately impose a total ban on abortions the moment that Roe v. Wade is overturned. So once the Dobbs decision was out, 15 states tried to impose this trigger law and immediately put abortions into a total ban. However, some states were successfully able to enjoin these laws and put them under injunction, and therefore 3 states did not have these trigger laws go into full effect. And therefore, a total of 12 states are defined as treated, as we can see here in the red kind of states over there in the timeline, and the 3 were enjoined and therefore in the control group. There are 3 states that are worth mentioning as details of this timeline. So for Wyoming, they had a new total ban that was introduced not in 2022 as a trigger law, but in 2023, a year after. However, they were successfully able to put this under injunction, so they still remain as our control group. We have Missouri that previously had their trigger law under injunction. However, by 2024, after 2 years of enacting that total ban, they were able to successfully put that law back into injunction. However, they're still considered a treated group in our study because 2 years worth of clinic closures had already done the effect. And one last state is Indiana, where Indiana used to be a state that had their trigger law enjoined, so was in the control group. However, by 2023, they were able to enact a new total ban that went into full effect. With Indiana, I do 2 things. So first, I still include them in the control state because that would be a conservative estimate at most. But for sensitivity analysis, I also drop Indiana after the year 2023, and the results are very robust. So in total, there's approximately 18,000 tracts that are considered treated, And additional analyses in my paper also include states with gestational limits to see how that impact changes as well. So my main estimation strategy here is a difference in differences model, where the dependent variable of distance is measuring the distance from census tract I to the nearest abortion clinic at year T. The key treatment term here is this interaction between whether a tract was located in an abortion state, abortion ban state, that is subject to a trigger ban, and post-T, which is the indicator for post-Dobbs period, which begins in 2022. And for this design, I'm weighting the model by the total count of women ages 15 to 44 in each census tract, which allows us to interpret the key effect term as the increases in distance that women ages 15 to 44 specifically would have had to travel to reach to closest clinic post-Dobbs relative to the average distance pre-Dobbs. Equation 1b now adds poverty into the equation as a triple diff and diff model. The poverty variable here is a binary indicator of whether the census tract is weighted by the number of women in poverty or women above the federal poverty threshold for each census tract. So essentially what I'm doing here is I have two replicated observations of each census tracts and their distance, and this indicator tells us whether that observation was weighted by women in poverty versus women not in poverty, and it differences out that average so that we can have that additional increase of distance for those in poverty. So beta 3, which is our causal estimate of interest, indicates that additional increase in distance to nearest clinic for women in poverty relative to the women that are not in these total band states. And all models include census tract fixed effects, year fixed effects, which absorb all the time invariant and time invariant census tract characteristics as well as year-specific shocks. And robust standard errors are clustered at the state level. Equation 2 now gets at an event study design, which kind of makes up for the fact that differences, the diff and diff models tend to average all of the post-Dobbs treatments altogether. So to get at these period-specific effects, I'm using an event study design that has the reference time category as -1, so 1 year before the Dobbs decision. So all effects are measured relative to the period just before the Dobbs decision. So all of these, the main coefficient and our causal estimate here is interpreted as the additional effect of abortion bans at time S for women below the poverty threshold relative to women that are not in poverty, net of all of these contemporaneous poverty-related differences in the non-total ban states and relative to the pre-Dobbs baseline year of 2021. Same two-way fixed effects and robust standard errors are clustered at the state level as well. So to kind of move to first our descriptives, I want to show you this first map where it's a choropleth map of the pre-Dobbs clinic landscape at the census tract level. So darker shades indicate larger distances to nearest clinics, and these range from as low as 1 to 20 miles and up to 300 miles. So as expected, even before the overturning of Roe v. Wade, there were clear abortion desert states, in this case, a strip of deserts, but you can also see that there are some disparities even within each state where very few clinics did exist. What I want to draw your attention to specifically is the significance of being near borders of a state. So for example, in states like Missouri, they only mainly had access to abortion clinics due to their bordering lines of Indiana and Kansas in 2021. But states like California and New York, on the other hand, have a relative state advantage where most of them have great access to abortion clinics. But in the case of California, ironically, being near a border of Nevada might actually be a disadvantage because of their relative conservative policies and access to clinics. This second map now is showing you an overall distribution of abortion clinics across the United States, focusing on the spatial dynamics pre and post Dobbs. So to provide a clear comparison between the two periods, I'm overlaying two different geographic points of all abortion clinics that were open a year before the Dobbs decision and a year after the Dobbs decision. These gradients are indicating poverty levels by each county. So darker gradients mean higher levels of poverty. Red markers indicate facilities that were open in 2021 but now closed in 2023. And yellow markers are those that were open in 2021, continue to be open in 2023. There are a few stars that indicate newly opened facilities as well. Here, I want to also highlight three different things from this map. So first of all is the dynamic changes that are happening across the United States in terms of clinic access. So there's a lot of closures and openings happening in the span of 2 years, but also these dynamic changes are happening in even the most protective states like New York and California. So it's not something that's limited to total ban states, but something that's happening nationwide. Secondly, there is a correlation with counties that have higher levels of poverty to be more around the borders of their state. So this raises the question of whether census tracts with more women in poverty may also be closer to borders that ironically give them a buffer for clinic access. Lastly, I'm going to draw your attention to some of these abortion clinic deserts. So clearly, Texas is an abortion desert as of 2023, one that is very geographically large and entails a lot of distance as well. But what's more interesting are states like Louisiana and Mississippi that are completely secluded, and not only are they abortion deserts themselves, but they're also surrounded by other abortion deserts. I'll come back to this in the main analysis to see what kind of implications this location entails as well. So now moving on to the actual causal estimates, Table 1 presents findings from the difference in difference models, and the first two columns are analyses including all 12 total ban states, and the third and fourth column are excluding Texas. So essentially, I'm asking how much of the effect that we see in column 1 or 2 are driven by Texas alone because of its huge geographic size. But also, it's worth mentioning that many census tracts in Texas that don't have abortion clinics may not actually be highly populated to begin with. So even if their distance is very large to the closest clinic, it may not entail a lot of realistic challenges because there aren't a lot of women that are in need of these services. So that is all considered when excluding Texas from these main analyses. So results show a significant increase in distance of about 231 miles in tracts located in total ban states. When we include an additional poverty indicator, which is the column 2, the difference in experience distance increase between women below and above the federal poverty line is about -4 miles. However, this is not statistically significant. Excluding Texas, the magnitude decreases to additional 116 miles increased travel after the Dobbs decision. And excluding Texas, the poverty indicator points to additional burdens of 9 miles for women under, or 10 miles for women under poverty, but also statistically insignificant once we cluster standard errors at the state level. So now I'm moving on to the event study specification to kind of show you the dynamic differences and trends in these distance measures as well. So first, we see that there are no pre-trend differences from 2017 to 2021. And here, now I'm magnifying the results to kind of show you the post-treatment estimates. So we see a drastic increase in distance post-Dobbs that is persisting throughout 2025. Dynamic effects are present here where we see a peak of this distance increase in 2022, where clinics are forced to shut down and averaging an additional 247-mile increase in distance relative to 2021. The blue is including all states and the red is excluding Texas. But once we get to 2023, a year after the Dobbs decision, we actually see a decrease in this estimate to about 212 miles relative to 2021. So this is a 35-mile decrease, which may seem small compared to all of this huge 200, 300 scale. But when we consider the fact that most average distances to the clinic pre-Dobbs, even in total ban states, were about 44 miles, 35-mile decrease is actually equal to the amount that individuals would have had to travel pre-Dobbs. So it's quite a significant number. In 2024, this goes back up to approximately 232, but stays stable throughout 2025, indicating some stability that has been happening after 2024. But this dynamic effect kind of shows us and reflects that there might be some active relocations and openings of clinics in non-ban states that are changing the dynamics of distance and access in general. When excluding Texas, the results are pretty similar, but rather we see a continuous decline. So even if the magnitudes are smaller, we see a peak in 2022 of a 127-mile increase, which decreases to 116 in 2023 and decreases to about 110 after 2024 and stays the same throughout. Now, going back to panel B, here we're looking at the additional distance increase at each time period that women in poverty and total band census tracts experience relative to those in less restrictive states and relative to pre-Dobbs year. So kind of confirming the diff and diff results, we see no significant difference in average for women in all total band states. Once again, the blue dots. Once we exclude Texas, we do see a point estimate becoming positive of approximately 10 miles, indicating a possible additional burden. However, these estimates are not statistically significant either. One caveat to this is the original analysis of this paper basically used a poverty measure that indicates being in the highest poverty quartile for census tracts. So if a census tract had 30% or more of their tract population in poverty, they had a binary indicator of being in the highest poverty quartile. And when we analyzed it with this specification, these models do have a significant effect of additional burdens for total band states and for higher poverty census tracts. I'm happy to talk more about this during the Q&A as to why this can yield different identifications, but the main difference here is that we are weighting based on the real experiences of women and the number of women that are in poverty in each census tract versus just indicating a census tract that is further away that might not actually be populated to begin with. So now I'm going back to the previous mentioned island states where they are isolated abortion deserts that are surrounded by other abortion deserts as well. So two things are clear here. First of all, that the effects are much larger by about rising up to like 305 miles approximately. And women under the poverty line are not experiencing accumulated additional burdens of excess compared to wealthier women. And if anything, they have a relative buffer. Although the magnitude of -5 miles is not huge compared to the 300 miles that they additionally have to travel post-Dobbs, it does kind of get at the fact that poor women are not more disadvantaged than those that are not when you're living in a state that is already so disadvantaged and polarized to begin with. So all in all, how do we make sense of these results? I'm going to show you this descriptive map that now looks at the difference in distances from 2025, the most recent data, to 2021, which is prior to Dobbs. This spatial distribution offers a possible explanation to the results that we're seeing today. So first, contrary to the strip that we saw earlier in the 2021 data and map, the difference in distance that women actually feel and the differences from 2021 versus 2025 are much more concentrated in these total band states that are isolated from other neighboring states. So it really highlights the interdependence of state dynamics of how neighboring states play a really important role in providing access for women in need of reproductive health care. For example, when we look at Texas, the side that is not bordering New Mexico is the darkest shade and gradients. And for states like Louisiana and Mississippi, the island states, all states that we highlighted before are experiencing the most increases in distance because of the fact that they don't have neighboring states. And secondly, this offers an explanation of why women in poverty are not necessarily experiencing additional burdens of distance. So if more women in poverty are actually concentrated near the borderlines, they may be actually at a buffer where other neighboring states can offer out-of-state minimal advantage in distance. However, it really highlights the fact that when you are in a state that is so disadvantaged to begin with, there really is no additional difference that women in poverty are facing because of this polarized context. So wrapping up the presentation, in conclusion, census tracts in states with trigger laws experience an estimated increase in clinic distance of approximately 247 miles. And depending on the specification of what kinds of states we include, the magnitudes of these estimates do differ. But one thing is clear that these effects are relatively unchanged after 2023, and they do hit a peak at 2022, suggesting some dynamic effects that are going on post-Dobbs. For the question of do women in poverty experience disproportionate travel burdens, when looking at distance itself in the highest poverty census tract, this might be true. However, when taking into consideration how many people are actually living in these census tracts, women in poverty are not showing any significant difference in experienced travel burdens. This paper kind of highlights the socioeconomic inequalities that are exacerbated through spatial inequalities, especially in the context of state polarization, really implying a widening gap of reproductive health access and outcomes across state borders. This also highlights the role of neighboring states and proximity to borders and the interdependent dynamics that happen there. Before ending the presentation, I'd like to just think about the implications of what this 200, 300-mile increase in distance actually means. In the Vice News, there's a really interesting interview with a case of a Texas woman having to travel to Oklahoma City for an abortion, and this is prior to the Dobbs decision. There was extreme levels of economic precarity that are entailed with traveling across states, but also a lot of psychological distress that is happening here. So, for example, in this interview, Jasmine states that she would need $50 to drive to Oklahoma City, $60 to, or $150 for new tires, hotel fees, $150, childcare, and procedural costs, all adding up to 150, 70, 650. All of these additional burdens are something that overlays on top of her economic precarity to begin with, but also within clinics that are outside of Texas had to also endure the burdens that have become larger after these restrictive abortions. So the Trust Woman Oklahoma City dealt with even bigger surges in people coming from Texas borders. So 1 year before these restrictive laws, they had 11 Texans come into their facilities, now increasing to 127. So this really highlights the real life experiences that women have to go through in order to receive basic reproductive care and the consequences of state polarization in the United States related to reproductive autonomy. Thank you so much for listening, and I'm looking forward to your questions and comments.